All right. Good afternoon. I hope everyone is well. I see some music coming up. We'll play a little background music while people gather. Let's see. Yeah, I think we can get started because I know we definitely want to have time to really dig into this conversation. But to kick it off officially, my name is Vanessa Nazario. I'm the Chief Belonging and Equity Officer of Memorial Healthcare System, and I have the honor and privilege of working with a lot of amazing people here within our organization to really lift up conversations that are laser focused on addressing health disparities and health inequities, all towards really working towards achieving equitable outcomes for our rich, diverse patient populations that we're so blessed and fortunate to serve each and every single day. And we know that we can't do this alone. We have some strong community partners, and you'll hear from one in a little bit during this conversation today. And we have some courageous patients that are also are always agreeable to telling their story. But today, we are really honoring Sickle Cell Awareness Month. And, we decided to host this virtual town hall to really bring together a collective group of people to really unpack this conversation around sickle cell awareness and combating sort of the stigma and the bias that exists, particularly for our sickle cell warriors who, have to sort of navigate different sort of systems to access great care. You'll hear a little bit about the program that we have at Memorial in a little bit, but I welcome our guests who are possibly joining us from different sources outside of the healthcare system. Thank you for spending time with us this late afternoon again to have a conversation around sickle cell awareness. And before we proceed, I wanted to give a shout out to the education committee. We actually have a sickle cell awareness education committee. Kemba is a member of it, along with some other amazing people who are probably on the line right now. And I wanted to thank you for helping to organize today. And of course, marketing, right? And all the different players that come together to bring this together. My colleague Emilia, who's helping us with the technical component behind the scenes here, because it takes a lot to pull together an event. But without further ado, I'm going to just go around the horn real quick and ask my guests here to introduce themselves. And then Dr. Ogunsile will do a formal presentation. Once she's wrapped up with that, she'll invite Kemba and Quinn to join her for a panel conversation. Well, you'll hear a little bit more about, their personal sort of stories, and we'll go from there. But Dr. O, I'll start with you. What did you do? Introduce yourself to the audience. And please make sure you keep yourselves on mute for those that are joining us, because we are recording and streaming. Dr. O?
Yes, good afternoon, everyone. My name is Dr. Joy Ogunsile. I am the medical director of the Memorial Sickle Cell Medical Home located here in Hollywood, Florida.
Thank you, Dr. Ogunsile. Kemba?
Good afternoon, everyone. I'm Kemba Garcia, president of Advancing Sickle Cell Advocacy Project. I'm also a certified sickle cell educator and counselor, and I'm the mom of an adult daughter with sickle cell SS disease. I'm super happy to be here.
And again, like I mentioned a little earlier, Kemba is an instrumental community partner of ours, and we partner on a lot of different initiatives. So we're so thankful for that partnership, because again, we can't do this work alone. Quinn?
Great afternoon, everyone. My name is Quinn Turnquest. I am a sickle cell survivor, and I'm grateful to be here to share my story with you all.
I love it. And before we sort of went live, Quinn mentioned that, he was thanking Memorial for hosting this session today, because he felt it was important to share stories, right, and raise awareness, collective awareness about sickle cell disease, and particularly the power of storytelling from the patient themselves, right, so sort of share what they've encountered and how they navigated, and hopefully some nuggets we can take away as clinical and non-clinical workers, all sort of working as a team here. So without further ado, Dr. Ogunsile, I'm going to turn it over to you for the formal presentation. And then when you're wrapped up with that, you'll ask Kemba and Quinn to come back on. Dr. O, the floor is yours.
Sounds great. I'm going to share my screen. Hopefully everything works. Good. I hope everyone can see my screen.
Yes.
Great. So good afternoon again, everyone. As I said earlier, my name is Dr. Ogunsile. I am the medical director of the Memorial Sickle Cell Medical Home. Today, I really wanted to tell you guys or give you guys a general overview of sickle cell disease And the way that I wanted to present it is in the way that I've heard a lot of the warriors that I take care of tell me in terms of things that they wish other providers know or people in the community would know about sickle cell disease. So some of the things that we would highlight during our discussion today will include really the inheritance pattern and epidemiology of sickle cell disease. We're going to touch base on pain crisis, which is one of the most common phenomenons that we see in sickle cell disease. We'll talk briefly about transfusions, as that tends to come up in the community and in the clinical settings too as well. And then very briefly about treatment options. I really don't want to spend too much time on this presentation. It's just really to give the highlights, because the stars of this this virtual town hall is Quinn and Kemba. And I think it's going to be really important that you guys hear from them too as well. Okay, so I'm going to do it as a patient. We have a patient who's going to walk us through her story with sickle cell disease. So very similar to many of the patients that I've seen. So meet Sierra. She was born in Florida in 1989. She was immediately told after birth that she has sickle cell disease. She knows her genotype, which is great. She has hemoglobin SS. And she says that her parents were not aware that they carried the sickle cell trait until she was born, of course. And during her early years, she tells us that there was great uncertainty of whether or not she was going to live to adulthood. She said many providers said that she probably wouldn't. So she's happy now that she's in her 30s that she did. And one of the questions that annoys her is that a lot of people, when she goes to the hospital, ask her how long has she been living with sickle cell disease, and we'll kind of go talk further about that. So let's take a step back and think about what happens in sickle cell disease. The crux of what happens in sickle cell disease is that there's an amino acid change in the red blood cell. This amino acid change makes the red blood cell become thicker and polymerizes under times of stress, which could be infection, dehydration, emotional stress. And when the amino acid change occurs, it causes polymerization, which causes the cells to become a sickle shape. Once they become the sickle shape, they're harder and more rigid, so they're more prone to hemolysis and breakdown. And this is what causes the anemia. In terms of how you get sickle cell disease, you're going to be born with it. So the question of how long have you been living with sickle cell disease is sometimes a question that to many people doesn't really make sense, because it is an inherited condition. Sometimes I think what medical providers, when they ask that, they're really just asking about when you were diagnosed, because we know that some people are diagnosed later in life, but when you see someone with sickle cell disease, you should know that they had this since birth. And sickle cell disease follows what we call Mendelian genetics. It is a recessive gene. So in order for someone to have it, the sickle cell disease, both of their parents must be carriers. And another thing to remember when we're thinking about the inheritance pattern of sickle cell disease is that with each offspring, which each delivery, there's going to be a 25% chance that that offspring will have sickle cell disease if their parents both have the trait. That doesn't go away with each subsequent delivery. Sometimes people say that, if I had one child with sickle cell disease, that means the next 3 children will not have it. That's not the case. So every single time there's a 25% chance. Looking at the prevalence of sickle cell disease in the United States, it is quoted that 100,000 Americans are affected with sickle cell disease. This is primarily in minority populations in the United States. So African Americans, Hispanic Americans are primarily affected. We primarily see people living with sickle cell disease along the East Coast, with the highest areas of sickle cell disease being Texas, Florida, where we are, and New York. There's one thing that I do think is important, as we have a mixed crowd of community providers and patients here, is really trying to close the gap of our sickle cell trait status. Here listed are pictures of the Black Panther movement in the 1970s, where they really organized an effort to educate people within the Black community about sickle cell disease, and also spearheaded testing for sickle cell disease and for sickle cell trait. And even still, with that occurring in the 1970s, we have a long way to go. Only about 16% of people who are African Americans know their trait status. And as I said before, with the inheritance pattern that occurs in sickle cell disease, it's really important to know this information when you are with your partner and you're thinking about having children. So if you don't know your trait status and you are a Black American or Hispanic American, I really want to encourage you to reach out to your primary care provider to get tested. You can also get tested at many local organizations within the area too. The most more common genotypes in the US with sickle cell disease are hemoglobin SS, hemoglobin S beta thalassemia null, beta thalassemia plus, and hemoglobin SC. Hemoglobin SS and S beta thalassemia null are generally thought to be the more severe forms of sickle cell disease, just because their hemoglobin level runs a little bit lower. Hemoglobin beta thalassemia plus and SC have higher hemoglobin levels, so it's often thought that these are less severe. However, we know as providers that patients don't really subscribe to this. They don't really do what the textbook says. I know a lot of patients with hemoglobin SC who have high hemoglobin levels who have a lot of complications with sickle cell disease. As I also know that there are patients that have SS who do well and have a hemoglobin of 7. But this is just to give a general knowledge of some of the laboratory findings that we see in sickle cell disease. Another thing to remember is that when you do go and get tested for whether or not you have the trait, you want to make sure that they're not only testing you for sickle cell trait. The reason why I show the 4 different genotypes is because there's so many different ways that you can get sickle cell disease. And sometimes people who have thalassemia trait, if they get with someone who has sickle cell trait, they can still have a child that has sickle cell disease. So it's so important that you get the full comprehensive test of a hemoglobin electrophoresis to determine whether or not there is a chance that you may have an offspring with sickle cell disease. So let's go back to Sierra's story. So we kind of addressed what her genotype is. So we know that she's supposed to be, quote unquote, the more severe form of sickle cell disease. We addressed that, you know, a lot of people, Black Americans in the US still don't know their trait status, but hopefully I encourage everybody on this call, if you don't know it, that's going to be a priority for you. And now let's go and look at the life expectancy for someone with sickle cell disease. So the life expectancy in sickle cell disease for many years, for the last 3 decades, have primarily been quoted around 42 to 46 years of age. And I really like to show this graph because one thing that this graph tells me is that there is hope that life expectancy will continue to increase over time. We see that measures that were put into place, such as the National Sickle Cell Control Act, penicillin, transfusions, and hydroxyurea really did make an impact on increasing the lifespan of individuals. So there was a period of time when patients with sickle cell disease were not making it into adulthood, and that is primarily in the early 70s. But since then, our patients have been making it well into adulthood, into the 40s too as well. So we really do have to be careful when we're thinking about how we talk about life expectancy to our warriors with sickle cell disease, knowing that this continues to change. And then again, like I said, this continues to change. There are some new reports as recent as this year that says that the life expectancy is indeed longer and suspected to be at around 53 years of age. And this was based on 94,000 individuals with sickle cell disease. So that's probably the majority of what we have in the US, and looking to see that the life expectancy is actually probably higher than what was expected before. So going back to Sierra, she now tells us that has a kid. She felt like she had excellent pediatric care. But the transition to adult medicine was hard. It was rough for her. She found a lot of issues in finding a provider who would take care of her with sickle cell disease. She knows that a lot of physicians felt like they were not comfortable, even if they were hematologists, oncologists, to take care of her condition. And she also noticed that the way that they treated her acute pain was different. One of her most significant frustrations was when she went to the hospital and healthcare professionals told her that she was not experiencing a crisis solely based on her laboratory values. So we'll talk a little bit more about this. So number one, transition in sickle cell disease is hard. It is hard in a lot of other chronic disease conditions, but mostly very much prevalent in sickle cell disease. This is a study that looked at kind of 3 different cohorts of individuals living with sickle cell disease. And we see that when we look at the life expectancy of individuals living with sickle cell disease, as I said before, it is increasing. So people are living into the ages where they will transition. However, we see that there is quite a rise in the slope of death that occurs when patients transition. So there is an increase of mortality from 0.6 to 1.4 100,000 persons between the ages of 15 to 24. And that has a lot to do with what Sierra was talking about, that there's a lack of adult providers that can be found, and that there is a difference between the care that's received with pediatrics compared to adults. Some other things that really affect transition is that sometimes warriors with sickle cell disease really don't know how to manage their sickle cell disease yet. It does come with time to understand your triggers. A lot of times there's a lack of trust in adult providers or providers in general in the emergency room and inpatient. And that has to do a lot with the battle with trying to get their pain controlled when they come in for acute crisis. There is also some evidence that suggests that the disease may get worse as you age. So there's more and more risk of having organ damage. And as we all get older, there's risk of having any other, disease process going on, such as diabetes or asthma. And again, we talked about coverage issues too as well. So I say all of this to say that we really need to have our hearts open to those who are transitioning, really invest in ways that we can make it easier on the medical side as a community, and working with our warriors to make this more seamless so that we don't continue to contribute to the high rates of mortality during the transition time. Now let's transition to vaso-occlusive episodes, which are also known as pain crises or pain events. This is the most common reason people with sickle cell disease go to the hospital. It counts for billions of dollars in healthcare costs to manage vaso-occlusive pain. What tends to happen is that you have blood vessel occlusion due to the sickling of the red blood cells that blocks the blood flow of the red blood cell. And that causes ischemia. That also causes inflammation. So a lot of times we see that a lot of our patients with sickle cell are going to have higher white blood cell count levels and higher platelet levels. Again, a sign of the inflammation that is occurring. This is definitely a painful event. Someone like me who does not have sickle cell disease would not be able to describe how painful this is for our warriors. But some of the things that I've heard before is that it feels like 1,000 fractured bones. I broke a couple bones playing soccer as a kid, so I know how painful that was. So thinking about 1,000 of that. Some people say childbirth doesn't even compare to the pain that is experienced during a pain crisis. People say that it feels like you're getting electrocuted, or if there's like glass running through your bones. So this is something that we really have to kind of make sure we're addressing correctly. One thing, as Sierra said, is that a lot of people like to think that laboratory values will tell you whether or not somebody has sickle cell disease. Somebody who has sickle cell disease is having an acute crisis, and it really doesn't. This is a patient that I I've seen that came in and his labs in steady state was white blood cell count 8.8, hemoglobin 10.8, his platelets were 286, and his retic was 7.6. And when he comes in for a crisis, they pretty much look the same. And this person is indeed in crisis. So the notion that laboratory values is the way to diagnose an acute vaso-occlusive crisis is really harmful for patients with sickle cell disease, because there's no evidence to suggest that. Indeed, most of the evidence suggests that that lab values are not helpful in diagnosing acute crisis. The reason why we do get labs is because some patients, when they do have an acute vaso-occlusive crisis, they may develop another serious complication, such as acute chest, splenic sequestration, and the laboratory values kind of clue us into the severity of the complications that they may develop. So diagnosing a painful crisis is always the gold standard, is also always the patient's self-report. There's no lab work findings, there's no radiographic findings, there's no vital sign findings that will tell you whether or not somebody is having an acute crisis. So as medical providers, that's something that we need to remember. When we think about how to treat this painful crisis event, there are guidelines that have been put in place for years. The first guidelines were placed about greater than 10 years ago, and that was the government placed that. And now the government has given the power to the American Society of Hematology to place guidelines to how we should treat sickle cell disease pain crisis, because it's such an important thing. And it really affects the outcomes of the patient. So if I was going to sum up the guidelines in a nutshell, number one, it needs to be prompt. For anyone coming to the emergency room or the day hospital, the guidelines said that you should be treating them within 1 hour of arrival. So with check-in and within that first arrival, that first hour, they need to be getting an IV pain med. And that's the way that we are supposed to treat them effectively. And if we do that, we're able to reduce their pain to the level that is needed. So a lot of times, just in the ED, so a lot of times they don't have to go be admitted to the hospital. It really improves their quality of life, and it really just improves their disease process overall. Another thing that is highlighted is that it needs to be individualized. What works for one person is not going to work for another. And a lot of times pain management is really based on what the patient is taking at home. So what they recommend is that most patients have a pain plan, a pain passport, individualized care plan that is created between their outpatient provider and themselves, and that the emergency department and inpatient department follows this. And then frequent reassessments. You know, if we put the orders in and we come back and check them the next day, that's unacceptable. We really need to be checking in on them, you know, in the beginning every 30 to 60 minutes, just to see where their pain control is, because they may need to be down titrated or up titrated. But these are the guidelines that are essentially from the government that we really need to make sure that we're doing as we strive to better standard practices. Another thing that the guidelines recommend is a sickle cell disease specific hospital that can really take in the treatment of acute vaso-occlusive crisis. And they said using this hospital, which is a day hospital or infusion centers, is typically preferred over typical ED-based care. And at Memorial, we do have that. So we are in line with the guidelines for that. Our center is located at 3700 Johnson Street, which is across the street from the adult emergency room, with the hours of Monday through Friday from 8 to 6. The last patient we take is at 1 p.m. Patients really love that this is here for them, mainly because it's a quiet setting. They avoid the triage and the waiting area of the ED. They know that everyone in our clinic is experts in sickle cell disease too as well, and we're always able to provide aggressive treatment. So if you do see a patient in an emergency room, please feel free to have them come over to our clinic to see if we have spots available so that we can take them for that day. And then this is just our team of providers. Sorry that's a little bit dark, but we have a nurse manager dedicated to sickle cell disease. We have our nurses that only see sickle cell disease. We have our adult providers here, our office staff, our MAs, primary care, health wellness coach. So really a team-based approach that we have set up here at Memorial. Lastly, when we're thinking about pain and sickle cell disease, we must talk about chronic pain. Chronic pain is an entity that we are recognizing more and more over the last 10 years. And we define chronic pain as having pain on most days that last over 6 months. And chronic daily pain is quite different than having vaso-occlusive crises. So these are pain that you have every single day that is not in line with acute vaso-occlusive crisis. We know that this affects a lot of people with sickle cell disease, especially as they get older. And it makes sense, right? Because you have all these acute crises that are affecting the red blood cells, and over the years that affects your bones, your nerves, and things of that nature. And then as you age, you're going to develop chronic pain. The main thing to know about chronic pain is that we do have to treat that differently than acute pain. Acute pain usually just focuses on pain control with, IV opioids or non-opioids, whereas chronic pain, we really need to think about other issues such as the biological nature of it, the neuropsychological, and the social environmental complex too as well. So now, going back to what Sierra is telling us, another part of her story is that she's really confused about transfusions and sickle cell disease. She has a hemoglobin level of 7 to 8. However, she doesn't know when she's supposed to get transfused. A lot of times when she gets admitted, her hemoglobin drops below 7, and the inpatient provider is telling her that she has to get a transfusion. She feels fine. Sometimes the inpatient provider says that if you don't get it, it will be AMA, and she's worried about her insurance. So she wants to understand what the deal is with transfusions in sickle cell disease, and we'll try to touch base with this here briefly. So why are transfusions helpful in sickle cell disease? Blood transfusions are a form of disease modifying therapy in sickle cell disease. They can prevent acute complications and chronic complications of sickle cell disease. And there's 2 goals of transfusions. One is to increase the hemoglobin level, and that increases the oxygen carrying capacity of red blood cells. But then the other is also to reduce the amount of sickle cells you have. And that second goal of transfusions is quite different than what we see for the whole general population. Usually if you're getting a blood transfusion, it's because your hemoglobin is low and we're trying to increase it. But with sickle cell, there's 2 goals. And that's really important because there's many different ways to transfuse in sickle cell disease, because we're really trying to not only increase the hemoglobin level, but really more importantly is to reduce the amount of hemoglobin S cells. So basically what this is supposed to show is that, let's say if you have a concentrated amount of liquid, and our goal is just to get all of this concentrated amount out. We could do simple transfusions where we could just put water on top and we would just dilute it a little bit. Whereas if we were to take all of this out and put a new substance in, we have really more effectively achieved our purpose. So there are about 3 different ways of transfusions in sickle cell. Right now at Memorial, we only do 2 of the 3, and hopefully down the line we can do all 3. So there is red cell exchanges, which is completed with a machine. And then there's also manual exchanges where we're removing blood through phlebotomy at bedside, and then we give 2 units, and then we have the simple or top-up transfusions. Red blood cell exchanges are quite nice because they remove the sickle cells, and they also help to make sure that we don't get iron overloaded as quickly. And what are the reasons why we transfuse? There's a good list. So symptomatic anemia. So we don't necessarily have to transfuse just because the hemoglobin is less than 7. We really want to make sure that the patient's not having symptoms of it. A lot of times with being in the hospital, people are getting fluids, they're getting blood draws. They're going to drop a little bit, but many times the body will recover on its own. And as long as they're not having any of the other serious complications of sickle cell disease, such as splenic sequestration, stroke, liver, multi-organ failure, and pregnancy, pregnancy is a different thing, but as long as they're not having any other complications, we don't necessarily have to transfuse them. So again, just remember that, the transfusion threshold for everyone else that has sickle cell disease doesn't necessarily apply. We really need to think about other reasons to transfuse while they're admitted. And we do not just transfuse because we think that it's going to decrease their current pain crisis. No, there's many studies that have showed that doing that is detrimental because it causes iron overload over time and red blood cell antibodies. Further, the risk of transfusions, as I mentioned, are iron overload, red blood cell antibodies. There's a condition called hyperhemolysis, and there's other transfusion reactions. And this is just another plug for everyone in the community that in terms of red blood cell antibodies, that risk of developing that is lower if blood comes from the same ethnicity. The donor is the same ethnicity as the recipient. So we really need people in the Black populations, Hispanic populations to donate blood because it's blood that patients with sickle cell disease will respond easier to, just because we're all within the same ethnicity. All right, so now Sierra tells us that over the last year, it's been a rough year for her. She has had multiple crises and now has lost her job, and this has led to financial strain for her family. And she's feeling a little bit more down and depressed, and she knows that this is also creating further pain for her. She really wants to stop this pattern because she didn't have this before. And she just doesn't know what to do because she has heard that there's really not that much in terms of treatment for sickle cell disease. So we'll see if we can help her. So this is just a plug. This is a great study that shows that the quality of life in sickle cell disease is quite poor. On one end, when we think of high quality of life, this is the healthy adults, and on the other end, this is the low quality of life, and this is on patients on hemodialysis where they have to go 3 times a week and stay there for a period of time. And we see that sickle cell disease does score on the lower end of quality of life. Patients with cancer actually score higher than patients with sickle cell disease. So the quality of life for many individuals with sickle cell disease can be quite low, and something that we have to take into account. And this is something that patients really strive for. They want their quality of life to be better. And quality of life has a lot more to do than just what I can do as a medical provider. There's other stuff that patients with sickle cell disease have to fight on the daily. There's bias, there's stigma from healthcare providers, there's social determinants of health. And our patient, Sierra, she lost her job, so there's financial strain and living situation, transportation barriers, and of course racism too, that all impacts the quality of life that patients with sickle cell disease have. And this unfortunately can develop into depression. So there's very high rates of depression in individuals with sickle cell disease. Primarily due to the pain, the treatment, the racism, everything. And there was a study that showed that the rate of depression in individuals with sickle cell disease is 3 times higher than that of the general population. So as a community, as medical providers, we really have to make this priority that we are helping patients with sickle cell disease and their mental health with coping with stress. It's just as important as treating their pain, is that we have avenues that we can help them with managing stress too as well. In terms of treatment options for sickle cell disease, there are disease modifying therapies, and these are therapies that delay or slow the progression of sickle cell disease because it treats the underlying cause, whereas there's symptomatic therapy that really just treats symptoms. So a symptomatic therapy would be like pain medicine. It just treats your symptoms for that moment, but it's not attacking the underlying cause. So we do have some disease modifying therapies, not a lot. We do need to do better. but we have hydroxyurea, and that has been on the market since 1998. We have Endari, voxelotor, crizanlizumab, and transfusions. I'll go through that quickly. And then lastly, there are curative therapies. I'm sorry that the slide is a little bit blurry, but there are curative options now, and they continue to optimize these options. There's a lot of research and clinical trials in making these options more tolerable for not only children, but adults too. So there's bone marrow and stem cell transplant, and also gene therapy that is available. So as always, I always say maintain a positive outlook for the future. We have a long way to go, but have made significant progress, I would say, in the last 10 years with sickle cell disease. So who knows what we're going to do in the next 10 to 20. And thank you guys for your time. I will stop sharing, and we're going to save our questions if you guys have any at the end. But at this moment, I would like to invite Quinn and Kemba back onto the screen so that we can move into our panel discussion. All right, guys. Well, thank you again for being part of our panel. And I would just want to start off by first asking both of you guys to reintroduce yourself. And if you would like to give details of where you grew up, how long you've been in South Florida, and things of that nature that you think would be helpful, you can do that as well. So Kemba, I'll let you go first.
Thank you. And I really enjoyed your presentation, Dr. Ogunsile. You touched on a lot of serious things that impact our community, and a lot of it resonated with me. I just wanted to say that the labs, my daughter's been asked many times, how long have you had sickle cell by medical professionals? The depression, quality of life, blood transfusion, all that resonated with me. Again, my name is Kemba Gosia. I'm president of Advancing Sickle Cell Advocacy Project. I'm also the mom of an adult living with sickle cell disease, hemoglobin SS. I was born and raised here in Florida. Just to give a little quick story about myself, when my daughter transitioned, you touched on that as well, and how a lot of the children get lost in that transition phase. When my daughter transitioned from adult care, from pediatric to adult care, I noticed that there was a serious, huge gap, just like Sierra stated, in her quality of care. When children present to the hospital, everyone wants to help. No one questions if they're in pain, is believed immediately. I know that for my daughter's case, when we became to adulthood, that was not the case. I've never felt even as a Black woman, a minority, I've never personally felt that I had to prove that I was sick to anyone when I went to the hospital or anything like that. I just was going for help. But I know that for my daughter and a lot of sickle cell warriors, that's not the case. So that's how ASAP got started, by wanting to create change in the sickle cell community and address a lot of the disparities and be a support for our sickle cell warriors.
It's amazing. Thank you, Kemba, for sharing that. And we'll go back and talk about ASAP a little bit more too, because I know a lot of people are interested in participating and being part too as well. Quinn, why don't you tell us a little bit about yourself?
Great presentation, Dr. O. My name is Quinn Turnquist. I was born and raised here in Hollywood, Florida. As Kemba mentioned, we always get the question of how long have you had sickle cell? And it's not that people are being facetious about asking. It's just they're ignorant to how sickle cell actually happens as a generic. All right. So I was actually diagnosed at 6 months old with the disease. I have been fighting sickle cell more so in my younger years, were the troublesome times for me. I've learned to develop a chemistry with myself to learn my body that allowed me a very narrow way to actually manage the sickle cell pain. Hands down, in my opinion, Memorial Healthcare is the best way to go when it comes to sickle cell. I have not trusted any other healthcare providers. I haven't went to any other hospitals. I trust my health in the hands of Memorial Healthcare. Dr. O, Dr. Joyce Brown, Dr. Volfovich, they have been phenomenal when it comes down to managing the pain of a sickle cell crisis and the sickle cell patients. I appreciate you, Dr. Owen, Dr. Joyce Brown. I've seen her on here, for your care and your expertise when it comes down to this disease.
Thank you guys. So one of the questions I wanted to ask you is if you could find one word that sums up your experience with sickle cell disease, what would that be? And tell me why. And whoever wants to go first can go first with that.
After you, Kemba.
My word would be scary. As a mother, you're supposed to be able to make things better for your child when they're not feeling well. And it's a very scary feeling when you have no control over the disease process and what's happening. It's also very scary when you know that the experience that a lot of adult sickle cell warriors have to go through when they're seeking care. And it's also very scary to me, the fact that she may not come out of the hospital this time. You know, I've lost several loved ones to sickle cell disease, as well as I know there are people on here as well who has experienced the same thing. So those things are very scary for me. And the fact that I'm her biggest advocate, and I know a lot of times a lot of adults don't have that advocate on their side. And if something happens to me, what will happen to her? All those things are pretty scary to me.
That's really powerful, Kemba. It's really powerful. Quinn, what would you say?
My word would be grateful. The reason why I would say grateful is because I feel like God chose me to be the mouthpiece when it comes down to sickle cell. A lot of people don't understand this disease, and sometimes as a child and you're going through life and things are happening and other people don't understand, sometimes it feels like you're an outcast. Right. You stay in the hospital more than the average person. You're sick more than the average person. You're missing out on memories that most people can actually share and talk about, but you're not there because of your sickness or your affliction. Right. But for me, it was more so that I received the mission that God actually put here for me. Right. And I feel like I was a vessel chosen to actually be able to go back and give to the people that are going through it, that don't understand it. I've seen grown people go through it that was just completely lost. You have to understand sickle cell is something that happens. And like Dr. O said in her presentation, some people aren't diagnosed until later in life. They don't have no signs of sickle cell, no sickness, nothing. And then one day it hits them. And then it's terrifying because they don't know where to turn. They don't know what's going on. I never experienced this before. But in my situation, I felt like he used me to actually be able to help those people. All right. I can actually tell people how to get through a crisis if they can describe to me the pain they're feeling. Sickle cell isn't just one pain. And a lot of people think it's just one pain that you're feeling. No, there's multiple pains that you're feeling. They're happening at different times, sometimes simultaneously, and you have to be able to identify that. And most people can't because they don't understand what's going on. With my situation, because I was so sick when I was young, I knew that I had to develop a chemistry and an understanding for my body that allowed me to be able to help other people get through this sickness and through the pain of crisis. So for me, I'm grateful to be that vessel that God has chosen.
That both of this is just amazing. And I would say I don't have sickle cell disease, but my experience with it has been just passion. The reason why I got into sickle cell disease is a little bit above what you guys have talked about. I have some family members with sickle cell disease, and I experienced that scariness of not knowing the next steps. And then in terms of looking for a positive outlook and saying that, this is something that I was here to be put on the earth for, I said that at the end of my career, what's going to make me the most happy. And I knew that devoting my career to this would be, because it's been neglected for so long. And it takes people like Kemba and Quinn who are giving back, who are advocating. And that's why we have seen that the life expectancy has just increased over the couple of years, and so of that nature. So thank you guys for sharing that. That was just wonderful. My next question is to describe 3 challenges that you believe really affect the lives of individuals with sickle cell disease. And Quinn, I'll let you go first this time around.
The first challenge would be education. All right. And the reason I say that is, as I've mentioned when we first got on this call, a lot of people are confused, they're lost, they misinformed, miseducated when it comes to sickle cell. It's not highly talked about. There's not a lot of circulation going on about it. And sometimes when a person isn't familiar with what's going on, sometimes Googling it, now we have a thing called Google, right? Everybody looks up Google, and Google will give you opinions of everybody who had an opinion that day, right? And sometimes that can be detrimental to your health. So I would say education is the biggest challenge. Actually putting out the information that can actually help rather than speculate. The second challenge that I would say is, as Kemba mentioned, when we're going to these facilities, and because you look okay, you just look sick, you don't look like you're in a crisis, that can be very, very hurtful. I've been in crisis where I had to sit in the emergency room for an hour, hour and a half, 2 hours, and I seen someone with a minor cut get treated before me. And it was, hey, listen, although you can't see my pain, I'm quite sure it's way worse than that bloody finger, right? But it's hard to say that because that person is sick too, but at the same time, you can't see sickle cell pain. You just feel it. And sometimes after getting to that medical facility, most sickle cell patients have dealt with that pain for hours before even getting to the hospital, right? They haven't
Did I miss my
understood that
spot?
they were actually experiencing the
Did I miss
crisis.
my
So
spot?
by the time they get there,
Okay.
it's a situation where I'm on my last straw, right? I need help now. I need it quick. I need it fast. What can you do? And sometimes getting in those facilities can actually be a drag. So I think that's the second thing, just being able to have procedures in place in the emergency room that can actually monitor
Okay.
those situations. And the third issue that I would say, or the challenge, is dieting. Taking care of your body. As a sickler, it is vital to treat your body as a temple that it is. All right. We can't just put any and everything into our bodies and expect our bodies to function as normal people will function. People that can go and eat and drink and do whatever they desire to do. We don't have that privilege. And as a sickler, we have to be disciplined in that area of our lives.
Thank you. Kemba?
Thank you. I have to agree with Quinn on the education. That's extremely important. Education from the general public, education within our community, and education on behalf of the healthcare providers as well. That's definitely a big one. I think implicit biases and also stereotypes also really affect sickle cell warriors, is a challenge to them. I know, for instance, with my daughter, when she was 2 years old, she was given heavy medication. So when she transitioned to adult care, it was more so, there's a difference between an addiction and a tolerance, you know, if you've been given something as a child. So the stereotypes and implicit biasness is definitely something that I think is a huge challenge. And I think you touched on it in your presentation as well, the structural racism that exists. I know it's uncomfortable to talk about, but when you look at other disease processes like cystic fibrosis, which is also inherited, and you look at the funding that's gotten, the different drugs that's gotten, and you compare it to sickle cell, a lot of this does play a role into it. So those are some of the things that I think are challenges for our community.
Oh, absolutely. I totally agree with what both of you guys are saying. And, you know, it is our goal with Memorial to improve the emergency room experience. And, you know, my goal is that across the US, that is the same care that everyone would get. And that's why the government has mandated it. We really shouldn't see that people with bloody fingers are going before sickle cell disease. Of course, people who are having MI, strokes, they may go a little bit, but still, we still want to make sure that we are abiding by the guidelines. And I think the next question I have is for you, Kemba. Why is community advocacy so important? And tell us how community organizations can be helpful for warriors with sickle cell disease.
Well, I definitely think community advocacy is vital to making tangible changes within the sickle cell community, such as legislation, policy change to address the disparities and to improve the quality of life with those faced with sickle cell disease. Like Quinn stated, his word was grateful. It took me as someone with my child having sickle cell disease, just in a transparent moment, I was very angry and questioned, like, why would I have a child with this disease that's so difficult? And, you know, she's watching her sister play. She can't overexert herself. But I understood that I was given this child for a reason, to be one of those community advocates, to support not just only my daughter, but others that are affected by this illness. And so I believe that community-based organizations, we provide a safe, healthy, and supportive environment for sickle cell warriors. And I know that as a healthcare provider, you guys have a limited time with your patients as you're seeing them, but the community-based organization, we're like the boots on the ground, listening directly to the patients and working with them. And just like the African proverb, it takes a village to raise a child, it truly takes a village in the sickle cell community for us to make a difference, of all of us working together, the community-based organization, the warriors, the caregivers, the physicians, the pharmacists, the nurses, all of them. And we do have a support group as far as ASAP, where we are able to provide those support services for warriors. So I do think is very vital for the community-based organization to address those psychosocial needs that Sierra said about the depression, things like that. And it also affects the entire family.
Right.
The mom, the dad, the grandma, everyone who loves that warrior, it affects them as well. So I think that's the importance of the community-based organization.
That's awesome. And I know you're part of ASAP. If someone wants to join or be a part of that, how would they do that? And the information.
I can put that in the chat.
Okay, that's awesome. Okay, so I was told that I have one last question that we have to answer in a minute so that we can leave questions for the audience. I just want you guys to kind of leave with what you hope for the future to happen. If there's just in terms of sickle cell disease, I think we've said that before, but just kind of leave with some tidbits, some what you believe is going to be helpful and what you hope for in the near future with sickle cell disease. Quinn, would you like to go first?
Yeah, sure. My hope for the future is that we as a community, we join forces and do our part. You may not understand sickle cell, but there's a lot of people that do. All right. And it doesn't necessarily take you to be an expert for you to partake and actually getting things moving in the right direction here. There's a lot of educational pieces that actually needs to be done. There's a lot of outreach that needs to be done. We need to seek better health professionals to actually help those sicklers when they're in crisis. A lot of times, as you were saying in your presentation, like with Sierra, you lose jobs. You can't live life like the normal person. You know, certain things you're not physically able to do. We need to have things in place to help those people with those situations, whether it's transportation, whether it's nurses going to the homes, we having wellness checks, whatever. Anything that can actually get that person to actually be in a better situation. A lot of people are embarrassed. They're embarrassed to talk about it because they feel like they're less of. They feel like nobody understands, nobody knows what I'm going through. And to a certain extent, it's true, right? It's hard to describe sickle cell pain to someone who's never experienced that type of pain. That type of pain is very, very hurtful. Right? It's a very, very excruciating pain. It can be a shooting pain, a sharp pain. It can be a throb. It can be a whole series of events going on, and you're trying to figure it out, and you have no idea where it's even coming from. So we need to do better with having people that's experiencing these situations, maybe surveys, give them surveys, ask them how they're feeling, so they can be able to describe the pain to you. That way you as professionals and other professionals can actually know exactly how to treat it to its core. Sometimes we have situations where I've heard in the presentation also the racism part. I've been in situations where I had racism brought up against me because I was a Black man in the hospital, not in a gown, but I'm in a crisis. And they shut off my medications because I looked at normal. And the words to me was, oh, he's trying to get high, right? I'm trying to get high. Last thing I'm thinking about right now is getting high. I'm really trying to feel better, right? And those things play a big part in someone's well-being, right? We go through those stress moments because mentally we're distraught. We're trying to figure out how to get better. We don't want to be feeling the way we're feeling. And yet we have somebody else determining what kind of medication we get, when we get it, how do we get it, if we ever get it. And that can be a very, very big trigger for most people that's trying to understand why this is even happening in the first place.
That's awesome. So we're going to have to transition to questions. Vanessa, is there?
Yeah, and I think, honestly, Quinn just addressed the one question around what can we do to educate our healthcare workers to be more compassionate, because it's not something you can teach. And I think both Kemba and Quinn have done a remarkable job of imparting, I think, some important nuggets for our healthcare workers. But maybe, if you wanted to sum it up in maybe one sentence, Quinn, and maybe Kemba, I'll start with you, in terms of what can, we do to, you can't just, drink a compassion pill. Maybe one day we could, but not right now. So what would be your advice to a healthcare worker when you see someone that's in front of you and they're saying sickle cell, warrior, and they're in crisis? What would you say, Kemba, to that person?
Empathy, listen to the voice of the patient. They know their body more than anyone else. And they have a voice, compassion and empathy. And I just want to share this really in 20 seconds. When I was going to do the town hall, I found this article. This was from January 21st, 1997. My daughter was featured in the Miami Herald. This is her at the bottom. At this time, it says seeking hope for sickle cell. This was 26 years ago. And it resonated with me because I was like, wow, this was 26 years ago and we're still seeking hope and still seeking change. We're making strides, but we got to keep pushing, as Dr. Anderson Rose always says, the needle forward. So I think this forum that Memorial has provided is excellent. Dr. Ogunsile, excellent physician. This is what we need. These type of events is what we need in the community, so our voices can be heard, so we're all on the same page, because at the end of the day, we do need each other.
Amen to that, Quinn. And then Dr. O, maybe in the chat, if you want to address the whole sickler conversation that's happening around usage of that term, because I know we only have 1 minute. So Quinn, you want to close us out with just a word of advice for healthcare workers?
My word to healthcare workers would be this: imagine if it was you. Okay, treat everyone as if you were experiencing what they're telling you they're experiencing.
Yes.
Do not for 1 second think that someone is just hyping it up to make it seem like they just want treatment before everyone else. In that time of a crisis, it's the most painful experience of any person living at that point, right? I have never heard of anyone describe any pain that comes close to what I felt in a sickle cell crisis. I've seen people sick, I've seen people in bad situations, but to actually hear anyone describe their pain, it doesn't amount to a sickle cell crisis, because there's so many things happening at one time that it's hard to pinpoint where it's even coming from. All right, it's hard to stand, it's hard to sit, it's hard to lay, it's hard to think when it's happening. All right, so if anybody is in a situation and they're telling you, I have sickle cell, I'm going through something, I'm not sure what I'm going through, just take a step back and say, well, what if I was experiencing this? How would I want that person to treat me right now? Empathy
and compassion. Well said, and a great way to close out the program. Thank you so much, Quinn, Kemba, and Dr. Gunchale. Always remarkable information shared from you. And on behalf of all the audience members, and I hope you'll have a chance to quickly glance at the chat. You received a lot of love for being vulnerable, for sharing your stories. I know sometimes it's not easy getting on a microphone and sort of just exposing what you're feeling, what you're thinking. But please do know that, you know, we take it to heart, and this allows us to continue to grow. As we said a little earlier, there's such power in storytelling that we can't read in books, right? So thank you so much. Good evening to everyone. Thank you for joining Memorial Healthcare System on this virtual Sickle Cell Awareness Month Town Hall. And I'm delighted that you spent some time with us learning, and be well. Thank you so much. Thank you so much.
Thank you, Quinn, Kemba, you guys did a great job. I wish I could,
you
this
all.
could have lasted for another 30 minutes. This was
Yes.
amazing. Thank you guys so much, truly.
Bye.
Thank you for being a wonderful.
Thank you.